Thank you. It's a pleasure to be here this morning and to see all the innovation that occurred. This arcade was actually started in the society as it was a passion of a few of the members, and I would like to thank Eric Bauman and Beth Bryant, who have really made this format where we get to see the innovation and simulation and games-based learning demonstrated rather than just talked about. The contest itself, we had a group of 4 judges, and I would like to thank the other judges, Pam Jeffries and Laura Mangana and Jerry Stapleton. We used a rubric that included several different components as we walked around and heard about each one of these different projects. The promise of this type of learning is both the interactivity, but also the scalability and opportunity for interprofessional education. And I think you're going to hear about one of the innovations this morning. So I would like to first announce the runner-up for Lead Innovator, the SSH Award for Lead Innovator, and that is Joyce Flores for Brush Up. And the speaker you'll hear from this morning is a project called the Automated Intelligent Mentoring System, Applying Game Technology to Advance Medical Education. That was presented by Jeff Miller and Andrew Cross.
Andrew, you don't get to escape this. You're so much part of this team. I couldn't do it without you. First, I'd like to just say a big thank you. This is a bit of a shock and a tremendous honor to receive this recognition for this project that we've been working on. And after looking at all of our peers last night and their work, still a little bit surprised. So again, thank you very much, and thank you for organizing this. Our project is called the Automated Intelligent Mentoring System, and it came out from a dilemma that we face. And this is probably a dilemma that is common to everyone in the room as we think about this, and that is for our learners to acquire the requisite abilities to perform clinical procedural skills or engage in these types of activities, they need a lot of opportunity for deliberate and repetitive practice. We know from the literature this is a key piece that's going to make them more successful in achieving competence or mastery of a skill. Our problem is, though, is that to achieve that, we need the expertise of our faculty or instructors to be there over the shoulder of learners as they're starting to acquire these skills. And that's, quite frankly, impossible. We just don't have enough people. When we look at the numbers just at our school alone, we have 149 medical students per class. We have many different skills they have to acquire, and it's unrealistic for me to have faculty over their shoulder over the time. So to get this, we need the right devices, we need the right people, we need their presence, we need their expertise available to learners, and we need the individualized prescriptive feedback unique to that learner's practice in the moment. And we know practice is great, but practice certainly does not make permanent or perfect if they're practicing imperfectly. So in thinking about this a couple of years ago, we had this great idea. Well, if I can go to my living room and fire up my video game and learn how to do the Macarena with a Microsoft Kinect watching me and telling me what I'm not doing right, why couldn't we take and use the Microsoft Kinect to watch procedural skills and teach people how to do them more correctly? And that was sort of the genesis of the idea, is to take a off-the-shelf gaming technology that's very affordable, readily available, and apply it to the tools and pieces that are already within medical schools and different simulation centers, so that we're keeping the costs down, but starting to satisfy this need to provide a low-cost solution to provide this expertise and direct mentorship all the time. So big focus here was to develop this thing that actually maps three-dimensional time-space models of people doing things. So we map experts doing these procedures hundreds of times and create aggregate models that are 3D time-space models of what perfect performance looks like. And then we go and created an interface that allows a learner to come in and practice against that expert model while receiving real-time feedback. And the feedback could be visual, could be auditory, could be a combination. Or if they need to, they can actually call out to the system because it has voice activation and say, you know, Amy, I need some help. And the system will talk back to them and allow them to ask questions to receive additional guidance. I'll show you a couple of images in just a second. But the idea is they get more opportunity to engage in deliberate repetitive practice. And they get this opportunity to do it whenever they want, whenever they need to, at 3 a.m. when the faculty may not be there at all. Where it may be unrealistic. Or perhaps when we have remote locations, they can do it from there. They can do it halfway around the world and still receive expert mentorship and faculty guidance. So that was really our big genesis for this. And if we look at just the core schematic, it's actually a pretty simple set of devices cobbled together. We're using the simulation devices that you already have, the medical equipment that you already have, but we're putting a Connect in the middle of this and interfacing it with a software package we've created that takes these expert models and then watches a student perform and then grades them against the expert model. And we can do this for teaching and learning in a formative assessment fashion where they receive real-time feedback and guidance, or we can flip it into a summative assessment mode where they perform the procedure and it's cataloging what was correct and incorrect. So we can look at long-term performance or perhaps at a summative assessment level. So we go into the interface itself. We've actually created about 4 different procedures that we're experimenting with now. The one we demonstrated last night was endotracheal intubation via direct laryngoscopy. So a student goes into the system. We already have the simulator there. We have the equipment there. The first thing they do, log in to their account. They would select the procedure they want to do. And then the system maps them in. Because one of the things we have to do is scale each person against the master model. So we actually measure all of your joint measurements as they relate to the devices and equipment in front of you, and then you would enter into the procedure and start to engage it there. But other things we've also looked at, and the transferability of this technology is, you know, compression-only CPR, and looking at teaching proper body mechanics, not just rate and depth of compression, but putting your body into the right position to achieve success. Or patient transfer, moving patients laterally between 2 places. And one that I think is very important and tied to that is this notion of safe lifting and moving. You know, we lose a lot of very important people in the workforce every year to lifting and moving injuries. And one of the things that was always kind of troubling to me was, you know, every year I have to take this lifting and moving injury prevention course, and I go to the PowerPoint and I click through, and suddenly my back is safe. We thought, well, couldn't we apply this and actually teach people what their limitations are or what their restrictions might be, or are they even physically able to do these activities to try and improve the safety of the workforce out there so we don't lose as many of our valuable healthcare providers as we do? This is actually in the lab looking at it. This is actually the view from the Connect camera, so it is real-time 3D mapping the learner, and you see it's tracking the joint measurements and the green lines there, and then we have these zones where it's looking for the particular action and activity where the laryngoscope comes in. Is it at the proper angle, etc.? Are they in the proper sequence of events in this, you know, procedural timeline? And it's cataloging all of these things. And in this particular mode, this is where they're receiving active feedback. So they could look up at the screen at any time because they can see it too and say, okay, well, I'm still in the red zone. I need to keep moving my arm over. This is the correct place to be. So they get this sort of formative feedback step by step, or they can call out and ask for specific instruction, or I want to see the video again of how to do the procedure. So it allows them to go through and do it several different ways there. Very important to us, though, is that it's collecting a lot of data. And this data, I always tell people, data is the currency of a simulation center because I am a consumer of money. I don't create a lot of money. So our data is very important to us, but we think it's very important for our faculty, too. Some of these things we know we want them to achieve a certain outcome or competence level. Other things we believe mastery is the only way to go, where they need to be correct 100% of the time. So we're able to collect all this data and show trends over time and look at the sustainability of training. The system is also affording us the opportunity to set it up just about anywhere where you could just have periodic checkoff. So you could say, every 4 months we want to see you come through and successfully complete endotracheal intubation. And more recently, working with our residency programs and thinking about how we might incorporate this into the Milestones Project and cataloging data there to help them really substantiate the effectiveness of their residents in doing clinical procedural skills. So I promised I would keep it short. Again, we are so excited and very thankful to have this opportunity to share this with you. Our emails are up there. We're very happy to take any questions and answer anything real quick. We also have a little informational piece if anybody would like to get more information or talk with us further about the project. Thank you so much.
Some questions?
Okay. So what's next?
We've had people spitball lists of procedures to us that they'd like to see, and that's up in the hundreds now. So, you know, we're a grassroots effort at a small academic medical center in Norfolk, Virginia. So we're gathering the funds that we can through different research or endowment projects to continue developing these models. We've got it very, very close to a platform that could actually be delivered. There is a side project dealing with CPR that is commercially available, looking at the compression-only CPR. But again, we want to continue to refine the accuracy of the data stream. You know, one of the limitations for us currently is some of the technology. And to get to sub-millimeter resolution of movement and articulation of fingers, it's possible, but it's just unbelievably expensive to do. And we're really looking to keep this at a several $100 project, because then people will use it. And people that don't have access to multi-$1,000 accounts can use it. So it'd be geared really well to try and help penetrate some of the underserved populations or even into the third world where they may have limitations in access to faculty for this type of training.
Thanks.
Have you given any thought to using this technology for health systems to check competency checks of their providers, you know, in the work environment, competency-based OPPE, using it in focused professional practice evaluation and or skills days for working providers?
So that's a fantastic question. I think it's directly applicable to that. And one of the things it may actually help us do with the practicing professional is when they come in, they start by going through a system like this. And the things that they can do correctly, repetitively, perhaps we don't have to spend as much time working in that area, and we can focus our attention to areas that aren't as well for their clinical performance and streamline some of the training that we do, so we're not taking as much time of that practicing professional away from the clinical space. Yes, ma'am.
Sorry, could you push your mic? There you go.
Oh.
Thank you.
Have you thought about teaching aseptic technique with it and infection control? Proper aseptic technique?
I believe it would be possible. We have not specifically looked at that one yet. Basically, our limiting factor on this is it something that we can observe with the Connect camera? So if it's a procedure that we can observe, and we jokingly say, you know, we could teach someone how to rebuild a carburetor because we can see this, and it has steps and a sequence that must be followed. So, you know, the translation of this concept that we've shown with endotracheal intubation and lifting and moving and CPR should transfer to any procedure that's observable and has, you know, a rubric of how it should be done. Yes.
Other questions? If not, congratulations.
Thank you so much. Thank you.